Let's wait just 1 minute and I will start the recording. So I have started the recording. Those of you who have not joined us on time will be able to listen the audio recording. Today we have the 26th webinar of the Virtual Medical Consilium of the WHO Regional Office for Europe. And today's topic is dedicated to the results of the trials of shorter treatment regimens for drug-resistant TB. We have been waiting long for the results of the regional operational research of the endTB project, and today we have a unique opportunity to learn firsthand from the results, maybe ask some permanent questions to the researchers themselves. My name is Elmira Gurbanova. I'm the coordinator of the Virtual Medical Consilium, and I wanted to take just a few minutes to describe the logistical aspects of the webinar. We are delivering the webinar in 2 languages, in Russian and in English. And you can select the language you are most comfortable with. And you can also select the language of the slides. As I've already mentioned, we'll have recordings in both languages, and the recordings will be published later at the website of the Virtual Medical Consilium, alongside the slides which are going to be presented today. The program is that first we start with 3 speakers. 5-10 minutes will be provided for questions after the presentations, given the limited time available. I would like to ask you to put your questions in the chat so that we can put them together and present your questions to the speakers. And without further ado, I would like to pass the mic to Dr. Askar Yedilbayev from W Regional Office for Europe for the welcoming remarks. Dear Elmira, dear colleagues, thank you very much for the opportunity to open altogether this important 26th webinar of the Virtual Medical Consilium. I won't repeat the words about the importance of the information for practical use for the practitioner and the information you are going to be presented today. We are really glad and we are proud of the results and the first presentation, which I will present together with Alex. We are glad to say that you are part of this enormous project of the regional initiative. And as a welcoming word, I would like to also to congratulate all of you who celebrate the new year, Nowruz, so we call it, and welcome you and wish you all the best and the peace. So we can start the first presentation. Yes, Askar, presentation number 1. The results of the operational research on modified shorter treatment regimens for multi-drug resistant and rifampicin-resistant TB, lessons learned and the impact. So the floor is yours.
Спасибо большое, я буду говорить по-английски. So we will proceed to the next slide, and first of all, we would like to share the outline of this presentation. We will be providing some background of why this regional operational research initiative has started and been implemented, provide the details of the cohort characteristics, and share the findings of effectiveness and safety. Also, we'll discuss the predictors of the unsuccessful study outcomes and factors associated with development of adverse event of special interest. And also, we'll share finally the opportunities for improved programmatic decision-making. Next slide, please. So at the very start, I would like to express our deepest gratitude to, first of all, our patients who benefited from this wonderful opportunity of being treated with for the first time in history back in 2020 and 2021 with short treatment regimens, much shorter than it was recommended by them before. We also would like to thank for dedication, courage, and engagement and personal interest of all health providers involved, and specifically doctors, nurses in all countries introducing this modified shortage regimens, national tuberculosis programs, national study teams, and of course our experts from the task force on modified shorter regimens. Special thanks to our donors, the Global Fund, USAID, and partners who were involved in implementation. And for this analysis specifically, we would like to thank Dr. Jay Achar and Dr. Arak Sovanesyan for their determination, attention, and details of work in the analysis. Next slide. Next slide. As a background, I would like us to go back to the history of where we were in 2019 and early 2020. So by then, the WHO recommended the use of the new tuberculosis medications with proven level of efficacy and safety. And in December 2020, the WHO released guidelines on treatment of drug-resistant tuberculosis, in which, for the first time, the short treatment regimens have been recommended for the use under operational research conditions. This is related to the regimen B-PAL, and the 9-month-long regimen bedaquiline containing that was recommended for patients with MDR-TB, but under the programmatic use. However, as you can see, this regimen still had the sufficient pill burden, and some of the components of this regimen, specifically ethionamide, pyrazinamide, ethambutol, and high doses of isoniazid, were not considered appropriately to be for the use in the countries of the WHO European region because of the high level of baseline resistance already. Next slide. However, this was the opportunity of the only regimen to be used under programmatic conditions for patients to benefit from the shorter duration of treatment. However, the WHO in its guidelines of 2020 for drug-resistant TB treatment stated that any modifications to the standard regimens can be used under the operational research conditions. Next slide. And that is why WHO Euro took the leadership and proposed an establishment of the regional initiative, regional project that is focused on high burden countries and high priority countries of the WHO European region to introduce the modified shorter regimens for multi-drug resistant, rifampicin resistant tuberculosis that are more suitable for the drug resistant profile of our region. And this initiative was developed in everything that was required for the implementation of the regional research project was developed by the task force, by the expert group. Their names are listed here, and special thanks to them, who developed the regional operational research package comprising of several important and instrumental parts, such as study protocol, clinical guide, form completion guide, forms for the completion data collection, instrumentation education materials, patient consent forms, and others. And the objectives of this regional initiative was to facilitate the introduction of these modified regimens for MDR-TB under operational research conditions, using the conditions of operational research to boost and improve the good clinical care for MDR-TB, build the research and the clinical capacity in the countries, and contribute, of course, to the global knowledge in generation or in treatment of drug-resistant tuberculosis. 13 countries of the WHO European region listed here joined this important regional operational research initiative. Next slide. So the treatment regimens that were designed as for this operational research, they're listed here. And the logic of developing them was that these regimens should be fully oral, they should be 9-month long, because they should be modified to the standard 9-month long regimen. And as you can see, the regimen 1 is comprising of group A and group B medicines that were part of the longer treatment regimen for MDR-TB. And the regimen 2 differs from the regimen 1 only when cycloserine was replaced with delamanid due to the intolerance or documented drug resistance. And these regimens were included into the operational research protocol and recommended for adults. However, by then, only delamanid was recommended for patients over 3 years of age, and the delamanid containing a regimen of 4 drugs for 39 weeks was also recommended for children under 6 years of age, comprising of fluoroquinolone, delamanid, linezolid, and clofazimine. Next slide. So these are the objectives of the Regional Operational Research Initiative. The primary objective was to determine the treatment outcomes of patients who were treated with these modified regimens, who are short. Secondary objectives was also to assess the safety of these regimens and through the rates of adverse events, and also to determine the recurrence during the first 12 months after successful completion of treatment with modified regimens. Next slide. So this slide summarizes what have happened since the beginning of implementation. Again, 13 countries, all high priority from the WHO European region, have joined this regional initiative. And of course, this regional project have had many programmatic components because the operational research conditions are very close to the programmatic implementation. And with these regimens, in comparison with the longer ones, we were able to decrease the duration of treatment almost twice, because the treatment was 9 months, avoid the injectable agents, and decrease the pill burden down 6 times down. So the regional operational research package is on the right upper corner of this slide. You can see that, and you're well familiar with this. But as a result, the progress of implementation as of 1st of January, the regional cohort included 2,813 patients enrolled in these 13 countries, but also countries found comfortable of continuing enrollment after the end of enrollment into the regional cohort and enrolled more than 5,800 patients. So I can proudly say that as of today, we have about, in 13 countries, more than 8,600 patients on treatment with this mSTR regimens. And also this operational research project prepared the ground for the further operational research initiative, so an introduction of the short regimen for MDR-TB, which are currently recommended under program. Next slide. So through this operational research, the optimization to the clinical monitoring was introduced, which is part of the good clinical care. Some of the tests were old, and some of the tests were considered as not useful, as being used for the longer regimens. But again, the monitoring schedule for this operational research initiative did not differ that much and was not complicated, and was it was close to the routine programmatic implementation. But through fostering this in the operational research, we were fostering and supporting the good clinical care of patients that should be applied to everyone. Next slide. Of course, we will be speaking more in details about safety, but this is the list of adverse events of special interests that have been monitored within this regional operational research initiative. So these are 7 adverse events of special interest. Some of them are related to the cardiotoxicity, and of course, others were related to the use of to observe the possible linezolid toxicity. Next slide. And the routine cohort timeline was the following: that each of the country had been enrolling into the regional cohort during 12 months. And then patients have been followed up for 12 months, and then the patients were followed up for 12 months after successful completion of the treatment. So the enrollment started in the first country was Armenia at the end of August 2020, and we finished the enrollment of patients in the last country who joined this initiative in 2022. And then the 12-month follow-up occurred. Now we're in the period of when the analysis is happening, and the manuscript highlighting the results of this operational research have been prepared and submitted to the medical journal, Lancet, highlighting all the achievements. And I will pass now the floor to Alex to present the next slides on details of this operational research. Thank you.
Thank you so much, Askar. Dear colleagues, it's a pleasure to speak to you today, also in anticipation of the World TB Day. Just a technical issue for our translators, dear colleagues. When I will be saying next slide, please translate it also to Russian, because Elmira will be helping me to switch Russian slides, to run Russian slides. So, dear colleagues, let's begin with the cohort characteristics. And as usually when we present results of observational studies, it's important to see patient flow diagram, because it's also one of the potential sources for the bias. So, you know, as Askar mentioned, many on this call were actually people enrolling patients in the countries. So let's see how well we did with adherence to the inclusion and exclusion criteria. Overall, on the study sites, we have seen 7,200 patients with drug-resistant tuberculosis, with rifampicin-resistant tuberculosis. Of them, almost half have failed their screening, majorly due to resistance to fluoroquinolones or exposure to study drugs for over a month. Some patients also did not have results of drug susceptibility testing. So at the end, we had 4,149 patients who were eligible for inclusion. However, due to different reasons, which included, for example, patient social or medical conditions, or the fact that patient resided outside of study sites, or patient could not understand the concept of the study, they were not invited for the participation in the study. But also, of those not invited, about a half were not invited by the decision of clinicians, and that's something that we could have done better if we would strictly adhere to the inclusion criteria. So that's something which introduces in our study a certain bias. However, of those 4,149 eligible patients, 3,145 were invited to participate. That was 75%. And of them, 300 patients refused participation, were unwilling to sign the informed consent, or unwilling to discuss the study. And we ended up with 2,813 patients who constituted our safety cohort. Safety cohort constituted those who took at least one dose of the study treatment. And then certain patients were withdrawn, for example, because we later, based on the results of phenotypic DST, we discovered that they were resistant to one or more study drugs, or other ineligibility criteria that were discovered after patients were enrolled. So those patients were withdrawn, and the effectiveness cohort or treatment cohort constituted of 2,600 patients. So among those 2,600 patients, we assessed treatment outcomes. So let's have a look at our cohort. As you see, majority of our patients, 75%, were male, and this is traditional for the epidemic in the WHO European region. Also, majority of our patients were of able-bodied age. I'm sorry, Elmira, I forgot to say next line, but you are on the right side right now. Thank you. Yeah, so majority of patients were of able-bodied age. We also had some children under 15 years of age. Colleagues, please keep your mics muted. Thank you, that would help. And the quarter of patients was previously treated. As Askar mentioned, the primary regimen consisted of levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine, and we had 96% of patients on that regimen. Also, 3% of patients on the regimen where cycloserine was replaced with delamanid, and we did not have a lot of children under 6 years of age, but overall of the study population, 1% fulfilled this criteria to be assigned with regimen 3. And as I said, a quarter of patients was previously treated. Next slide. So when we are looking at the geographical distribution, we see that the majority of patients came from Ukraine, 42%, and also major contributors to the regional cohort were from Belarus, which enrolled almost 20% of patients, and other countries such as Uzbekistan, Kazakhstan, and others. Yeah, it is needed to note that some countries opt out for the country-wide enrollment, meaning that all study sites in the country were enrolling patients in the mSTR. That was the fact in Ukraine, Belarus, Latvia, for example, Moldova, Georgia, while others opted out for the kind of trial, not trial, but for pilot regions. So they selected pilot regions in which these regimens were introduced, and in parallel, in other regions, they were introducing longer treatment regimens or other relevant regimens. But for the country cohorts, those countries who were doing the research only in pilot regions, they also decided to scale up the study. But for the purposes of describing this cohort, we are just so we have this a mix of countries, those who opt out for country-wide enrollment and for the pilot regions. So if we go to the next slide, let's look at our population in terms of concomitant diseases. 10% of patients had HIV. In our cohort, 8%, almost 9%, had diabetes mellitus, and 11% had positive HCV status. And that was actually interesting because previously, neither programmatically nor in the studies, we did not study the prevalence of hepatitis C antigen among our population. And this study allowed us to see that the co-infection with hepatitis C is actually very common, and that requires also attention of clinicians. And also we had 2.5% of patients who had positive HBV status, hepatitis B status. If we go to the next slide, these are concomitant diseases as well. So we see that 3.7% of patients had history of peripheral neuropathy, and that's also important for the time when we will be discussing the safety features of these regimens. Less than 1% had history of kidney injury, and 4.5% had history of heart disease. And this study started in the COVID time, it was 2020. So we also decided to include the variable to test whether the patient had COVID-19 at baseline. And you see in our study, among 2,813 patients, 3% were COVID positive. But it's also needed to note that 1/5 of patients were not tested for COVID-19 at the admission into the hospital. Let's go to the next slide and see our population in terms of social and behavioral characteristics. So 61.5% were unemployed of able-bodied age. 90% of patients had only secondary education or lower, so they did not have any university degree. 3%, a bit less, were homeless, and 10% either had incarceration experience or were at the time of the study in the prison, because we did not have exclusion criteria for patients in the prison. And in those patients, in those countries where it was possible by the legislation to conduct the study in the prison sector, the patients were included. For example, that was the fact in Azerbaijan. Yeah, so you see, we also tried to not exclude a homeless patient to have our cohort representative as possible. Let's go to our next slide. So 15.7% of patients experience problematic alcohol use that led, for example, to problems with social or family life. And then 53%, so a bit more than half, were current smokers. 22% were malnourished with BMI below 18.5%, and about 3% were injection drug users. Now let's go to our next slide and see the baseline characteristics in terms that allow us to see where patients were in terms of the severity of disease. So you can see that majority of the patients, almost 60%, had either one-sided or two-sided cavities seen on X-ray. Also, radiographic changes were seen almost in all patients, almost in 100% of patients. 50% had abnormal one-sided changes, and other 50% abnormal two-sided changes. And finally, in terms of microscopy, 58% of patients had positive smear microscopy at baseline, indicating quite an advanced disease. Now let's go to a next slide, and we will talk now about the findings on effectiveness of these regimens. So when we are looking at the treatment success rate, so the success rate at the time of treatment completion, so in our cohort, 82.7% have successfully of patients have successfully completed their treatment and achieved either cured or completed status. 7% failed the study, but it's needed to note that in our study, conditions for failure were much stricter than in programmatic practice. For example, if the patient failed to adhere to 300 days or to 300 doses and received more doses or more days of treatment, then we classified him as or her as failed, while programmatically this patient could have been classified as cured. So in our case, even though the failure was quite a big number compared with the programmatic number of failures, but we need to remember that this failure included also patients that could have satisfied condition for cured. And also we had 4% of death and 5% of loss to follow-up. And when we compare this with programmatic outcomes, MDR-TB outcomes in 2019, we see a significant improvement, almost 15%. And this MDR-TB outcomes is for patients without known fluoroquinolone resistance. So you see this data is more or less comparable. And this is for 12 countries out of 13 included in our cohort. Let's go to the next slide and see an interesting observation which was made that there was significant difference in the outcomes between patients with HIV and without HIV. So patients, HIV negative patients had better end of treatment outcomes, 84%, while HIV positive patients had only 69% successful treatment outcome. It's also needed to note that most of the patients with HIV, they came from Ukraine, and Ukraine in our study had overall lower treatment success compared to other countries. So this HIV positive finding, it was related to the fact that HIV disease leads to worse treatment outcomes, but also to the fact that patients came from Ukraine. And overall, programmatically, we know that TB-HIV treatment outcomes in 2020 in euro, they were 47%. So we still see an improvement in treatment outcomes even among this cohort of patients. So the second safety, or the second effectiveness endpoint was the results of 12 months post-treatment follow-up. And unfortunately, in our study, we had quite high loss to follow-up rate during post-treatment observation. Around a quarter of all patients disappeared at certain point. It doesn't mean that they disappeared instantly after they completed their treatment, but they may attended 3 months or 6 months visit, but did not attend 12 months visit. So that's why we choose this methodology, which is called Kaplan-Meier estimates for time to unsuccessful outcomes, which allows us to censor those patients who were lost to follow-up, but not account them as unsuccessful study outcomes. So in our study, unsuccessful study outcomes included death, failure, death during treatment and follow-up, failure, loss to follow-up during treatment, and recurrence. And overall, we registered 25 cases of recurrence and 44 deaths during follow-up. So, and then we did this estimate, which showed us that 12 months after treatment completion, successful treatment completion, probability of remaining alive and free of tuberculosis, so basically not having unsuccessful treatment outcome, was 79%. It differed between the regimens, as you see, slightly more for the regimen with cycloserine and slightly less for regimen with delamanid. And also probability for the regimen for drugs was higher, 93%, but keep in mind that this was a regimen for children under 6 years of age, and monitoring of recurrence in children is quite difficult. So basically, yeah, recurrence rate for children is low. And then we did, next slide, please. And then we did independent analysis of predictors of unsuccessful study outcomes, univariate and multivariate. And we find out that unsuccessful study outcome, so the risk factors for unsuccessful study outcomes, which were again death, failure, loss to follow up during treatment, and recurrence, was different among certain groups. So for patients who are unemployed, they had 45% higher hazard of developing unsuccessful study outcomes. Then also patients who were aged 54, 64, they had 37 higher hazards than patients of 35 to 44. And also patients aged over 64, they had 2.0 times higher hazard compared with 35 to 44 age group again. Patients with excess alcohol use had 46% higher hazard. Patients with normal BMI had 22% lower hazard than those who were malnourished. And current smokers had 37% higher hazard again. And HIV positive patients, 57% higher hazard of unsuccessful study outcome. Patients with baseline anemia, 45% higher hazard. Patients with baseline elevated LT-IST, 39% higher hazard. And patients with two-sided cavities, 64% higher hazard. And then next slide, we will go to the safety outcomes. And again, next slide. So in this presentation, we decided to focus on only on presenting adverse events of interest of grade 3 and higher by the severity grading scale, because we find that adverse events of interest are better representations of safety associated with the study medicines, while serious adverse events, they tend to aggregate adverse events that are related to TB medicines, to TB disease itself, and also to health system failures. For example, there are some countries in which it is impossible to manage adverse events at the outpatient level, and patients need to be hospitalized to get free of charge treatment. And you know that hospitalization is one of the criteria to assign event as a serious adverse event. That's why we decided to focus only adverse events of interest, because we know that they are associated with the study drugs. We know it from the safety profile of the drugs. So let's go to the next slide. In our study, we observed 301 adverse events of interest. Askar showed you which were adverse events of interest in our study, among 252 participants. So overall, only 9% of patients experienced one or more adverse events of interest. 7.5% of patients had only one incidence of adverse events of interest, and 1.3, two or more. As you see, adverse events of interest usually appear early in the treatment, because once they appear, they get managed. Maybe dose gets reduced or the drug gets eliminated from the treatment regimen, and occurrence of them later in the treatment decreases. The most common adverse event of interest of grade 3 and higher in our study was myelosuppression. Of all adverse events, it consisted on almost a half. And then we also had a considerable number of QT interval prolongations, 16%, and 10% of all adverse events of interest were peripheral neuropathy. And you see either like other ones like hepatitis, optic neuritis, hypokalemia, and acute kidney injury, they were less frequent. Now let's look at the actions taken. That's a next slide. Actions taken and outcomes of adverse events of interest of grade 3 and higher. So in most cases, we did not need to withdraw a drug. So 55% of all adverse events of interest were resolved either by not changing a dose or reducing or just reducing a dose of the drug. Also, Elmira, please, next slide. Also, in 22% of adverse events of interest, we need to interrupt a drug, and only in 20% of adverse events of interest, we had to permanently withdraw a drug or the regimen, total regimen, like whole regimen. And in terms of the outcomes, as you see, almost a half of all adverse events of interest were successfully resolved, and about 40% were resolving at the time of treatment completion. Only 4% were resolved with sequelae, and 8% remained unresolved. And unfortunately, 2% of adverse events of interest, they led to death. And the next slide. Here we looked at the factors that were associated with development of adverse events of interest of grade 3 and higher during treatment. Again, univariate and multivariate analysis adjusted. So male patients had 28% lower hazard of adverse events versus female. Every 10 years increase in age was associated with 30% higher chance of getting adverse events of interest, of developing adverse events of interest. So the older you get, the higher is your chance to get adverse events. Also, the regimen with delamanid was associated with over 2.5-fold increased hazard of adverse events. Again, malnutrition was associated with adverse events of interest. It's 40% increase. Heart disease, 37% higher hazard of development of adverse events of interest. HIV positive patients again had 21% increased hazard, and people with hepatitis C had 64% elevated hazard of developing adverse events of interest. And this is again an important finding that hepatitis C should be managed to avoid adverse events of interest. And finally, the baseline disturbances such as increased creatinine, peripheral neuropathy, and increased bilirubin, and as well anemia, they also increase chance of developing adverse events of interest. And yeah, and that's all. But I want to thank our colleagues again, Jayachar and Arks Ovanisyan, for doing this analysis and investing a lot of time in preparing the results of this study. Next slide, Askar, over to you. Askar, you are muted.
Thank you very much. And would you please proceed to the next slide? As a conclusion, I would like to say that the impact of this regional operational research on the burden of drug-resistant tuberculosis is obvious, because throughout the years of implementation, there was a possibility to increase access to the effective and shorter and more safer treatment regimens than we were treating patients before in the countries of the WHO European region. Also, for the first time, we have been observing and witnessing the high treatment success rate and because of the decrease in those patients who are interrupting treatment and the loss to follow-up and development of unfavorable treatment outcomes. Through this operational research initiative that is so close to the programmatic conditions, we were able to promote good clinical care that can be applied for the routine programmatic approaches, not only for patients with drug-resistant TB, but also for all tuberculosis patients, and improve and optimize and make it more tailored the treatment schedule, treatment monitoring schedule. For health systems, of course, I mean, the transition to the fully oral and shorter regimens that are more safe, these are opening doors for treating patients at the outpatient settings. That is also reducing the unnecessary needs associated with hospitalization, but we were also being able to promote the people-centered approach throughout the implementation of this operational research and engagement and involvement of other partners, including the civil society organizations. So the decreased risk of nosocomial transmission was obvious because especially when the study was initiated, it was during the COVID-19 pandemic. And of course, treating patients with short and fully oral regimens allowed application of other alternative solutions to the mandatory daily visits to the clinic that decreased the chances of transmission of nosocomial transmission of TB, but also acquisition of COVID-19 infection. And as a result, I mean, this initiative has also contributed to the reduction of stigma and any discrimination that is associated with tuberculosis and drug-resistant tuberculosis, and decrease the household costs due to this disability. And of course, for us in the WHO European region, this initiative, we believe and we hope, and we will see it later in later reports on surveillance, that impact on the burden of TB was obvious. Next slide. And as a conclusion, I would like to not repeat that what was said by us before, but we hope that the mSTR regimens are indeed showing the promising results and have the potential to facilitate the achieving the regional targets that we have in the regional action plan by the 2025 of treatment success for MDR-TB of 80%. So it's also important to highlight, and Alex said that the recurrence rate of this regimens is very, very low and rare. It's 1% only. Of course, there is more work to do, especially with analyzing the predictors of unsuccessful treatment outcomes and address these determinants and look at every single factor that can further improve the treatment outcomes of our patients, both from the clinical and from the programmatic perspective. So with this, I would like to go on to the next slide and say that this slide is summarizing the relevance of the use of the modified shorter treatment regimens in the WHO European region. With the smaller numbers, you can see the enrollments into the regional cohort, and then that continued with in each of the country with enrollment of the national cohorts. And as you can see, as of now, we have more than 8,600 patients in all 13 countries. So countries, clinicians, you, dear colleagues, are finding these regimens as very instrumental and comfortable for patients, and safe and effective enough. But at the same time, these are the regimens in some of the countries is the only opportunity for patients to benefit from the shorter treatment regimens. And in those countries already transitioned, so gradually scaling up introduction of BPAL, MOXIE regimen. So these mSTR regimens are the only opportunity right now for the patients who are not eligible for BPAL MOXIE to benefit from the shorter duration. And I would like to really, at the very end, ask to proceed to the next slide. And once again, thank you everyone who are involved. Over.
Thank you very much, dear Alex, dear Askar, with the excellent presentations and detailed results. My congratulations to all of us with the excellent results. And of course, we still have a lot of work ahead of us in order to analyze some additional data that we obtained during this study. And once again, thank you very much. Dear colleagues, I would like to remind you that you have an opportunity to ask your questions in chat. We have very little time left, but even if we will not have enough time to answer your questions, you will be able to receive answers in our emails. And now I would like to give the floor to the next speaker, Dr. Lorenzo, Director of endTB project, who will present the endTB project results. Lorenzo, the floor is yours.
Thank you very much, Elmira, and thanks a lot, Askar and Alexander, for the invitation. It's really a pleasure to be in front of this big audience, also in correspondence of the World TB Day. And I see a lot of friends and collaborators also from the TBNet studies in the group. It's really a pleasure. I will be sharing my screen, but let me First of all, congratulate again. It's the second time I have the chance to see the presentation of the mSTR results. And I think this is really great. It's such as an important work and the huge amount of work. So I think everyone who has collaborated to this initiative should be really proud. Second. Can you see my presentation in the correct way? Okay, great. So I will be presenting, and it's of course a privilege for me to present results of the endTB trial. This is a very big collaborative project that has been implemented through many years by this consortium that you can see here below on the slides, which comprise the sponsor of the trial, Médecins Sans Frontières, or Doctor Without Borders from the section in Paris, France, together with colleagues from Partners in Health in Boston, US, IRD in Dubai, and the other implementation and scientific partners that you can see listed below on the slide. I am affiliated with Doctor Without Borders and to the National Reference Center for Mycobacteria in Paris. So first of all, a few words about the background and the design of the trial. So the endTB trial is part of a larger project, the endTB project, which started almost 10 years ago, and which goals were to expand access to new drugs, bedaquiline and delamanid at the time, together with repurposed drugs, and use them together to identify new, shorter regimen and to generate and disseminate high-quality evidence. This project was funded entirely by UNITED and comprised 3 different components. The endTB observational study, which is over since 2019, which included a lot of participants across 17 countries, and then 2 randomized controlled phase 3 trials, the endTB and endTBQ trials, which are really complementary as they included patients with rifampicin-resistant TB and fluoroquinolone susceptibility for endTB and fluoroquinolone resistance for endTBQ. So today we will be talking about the endTB clinical trial, while endTBQ trial is still ongoing in follow-up, and hopefully results will be available by the end of this year. So first of all, a few details about the design of the endTB trial. So this, as mentioned, is a randomized controlled phase 3 trial, which is open label, as there was no blinding for patients nor physicians, and non-inferiority trial, which therefore was aiming at, by comparing each experimental arm to the control, to find regimens which had a comparable efficacy, while the advantage would be the shorter duration. So each of the 5 experimental regimens will be compared, as you will see, to the control in terms of efficacy and safety. In terms of the randomization which has been used in this trial, this was not a standard randomization. It was an outcome adaptive randomization, which initially, as you can see, was fixed, as each new participant has 1/6 of chance of being randomized to each of the arms, and then the probabilities of new participants to be assigned to each arm was adjusted according to early treatment outcomes in terms of efficacy at week 8 and week 39, so that arms which were performing better in terms of efficacy had higher probabilities of randomization. And the goal, really, overarching goal of the trial, was not to find just one better arm or one excellent arm, but to actually detect as many non-inferior regimens as possible to give multiple treatment options to clinicians. And something to mention, as you will see, 4 out of 5 experimental arms include linezolid. Linezolid was given at what is now the standard dose of 600 milligrams daily, at the beginning, but then it was routinely reduced in terms of dose at week 16 or earlier if there was a need because of toxicity, to two possible dose reduction strategies, either 600 milligrams 3 times a week or 300 milligrams daily. And this was decided according to a secondary randomization. So this is basically our study design. We have a lot of arms, as you can see, and that complicates sometimes presenting the results. So please be patient. So we have 5 experimental arms, all 9-month duration, and 1 control. So let's start by the control. The control was the standard of care according to WHO recommendations. So this, of course, has evolved through the long years of inclusion in the trial. Overall, most participants by far in the control received the long individualized regimen of 18 months or more. And more than 80% of participants, even comparing them, the regimens to today's WHO recommendations, received adequate treatment regimens. And now let's have a look at the 5 experimental arms. So as mentioned, all 9 months of duration, all the arms included 1 new drug between bedaquiline and delamide. So bedaquiline for arm 1 and 2, delamide for arm 4 and 5, and both bedaquiline and delamide for arm 3. Then all the arms also included 1 or both of the repurposed drugs, clofazimine and linezolid in blue, as you can see. In green, you can see the fluoroquinolones. So this is fluoroquinolone susceptible TB. So each arm included a fluoroquinolone, either levo or moxifloxacin. And finally, all arms included pyrazinamide, which was given regardless of the results of drug susceptibility testing to all participants. Here you have a summary of the follow-up of participants in the trial. So first of all, participants had study visits each week during the first month, then monthly until the first year of study follow-up, and then visits were between 6 and 8 weeks. And all these procedures that you see listed here were performed. Here you have the 6 arms. I think it's interesting to underline that our primary endpoint and the primary comparisons were made at 73 weeks, which is around 17 months after randomization, which allowed to add enough post-treatment follow-up to detect eventual recurrences in the experimental arms. Here you have a summary of the eligibility criteria. I will only focus on inclusion here, in particular the most important inclusion criteria. So participants had to have proven pulmonary TB with rapid molecular testing showing rifampicin resistance and susceptibility to fluoroquinolones. We included adults, patients, or adolescents of 15 years of age or more. We excluded pregnant women, and as you can see here, we had a lot of other exclusion criteria, which are quite standard. So just a short slide to show what it means to actually perform a phase 3 randomized controlled trial. It's a lot of work and a lot of time. The first participant was recruited in 2017. And the last one was included at the end of 2021. In the midst of that, we opened 12 sites across 7 countries. We followed up patients out of the 754 participants in the study across COVID-19 through more than 18,000 visits overall. And here you can see in the map where these participants were recruited, with Peru being the biggest recruiter and Kazakhstan being the second most important recruiter. A few information about the analysis populations that I will be mentioning briefly during the rest of the presentation. First of all the safety results will be described in the safety population, which includes all randomized participants who received at least 1 dose of study treatment. And then we have two co-primary populations, which are both analyzed in the primary efficacy outcome, which are the modified intent to treat population, or MITT, which is defined as the safety population of patients who also have a positive cultural baseline and confirmed rifampicin-resistant TB. They have post-baseline data, and they don't have resistance to any of the drugs in the regimens, excluding pyrazinamide. And then the other co-primary population, the per protocol population, or PP, sorry, is the MITT population, but with some additional restrictions, only including participants who completed a protocol adherent course of treatment. And the protocol adherent course of treatment was defined as having received at least 80% of the expected doses within 120% of the expected duration. And also, patients were excluded from the PP population if they were exposed to 7 days or more of a prohibited concomitant medication. So here you have the CONSORT flowchart that shows, first of all, that we had around 50% of screening failure. And as mentioned, we included overall 754 participants, which were randomized across the 6 arms, as you can see here. Then we had a very little loss between the overall randomized population and the safety. So this is the safety population. It's really comparable. Then between the safety and the MITT population, we have a loss of around 5% of the total, which is mostly due to patients without a positive baseline culture or with resistance to fluoroquinolones at the phenotypic DST. And finally, here you have the per protocol population, where the loss was much bigger, around almost 20%, and basically due to the fact that a relevant proportion of participants, in particular in the control arm, did not reach these 80% of protocol expected adherence. So one final slide before coming to the main results of the study. So in the MITT population, which comprised 696 participants, here are the baseline characteristics. Overall, median age was 32 years. Majority of participants were male, with a BMI of 20.4 in median. Pyrazinamide resistance was quite high, more than 50%. And in terms of the main comorbidities, HIV positivity was detected in 14% of study participants, active hepatitis B in 2.4%, active hepatitis C in 3.7%, and diabetes in almost 15% of participants. 80% of participants had sputum smear positive TB, and cavities were found in 57% of study participants. 11% of them were priorly exposed to other second-line drugs for the treatment of TB. So here we are, we come to the efficacy results, which will be very condensed. So first of all, here you have the percentage of favorable outcome rates across the 5 experimental runs in yellow, and in purple you have the control. And this is in the MITT population. So first of all, let's stop here 1 second and focus on the overall outcome rates. So almost all arms had 80% or more efficacy rates, which is great, and it's really reassuring. And in particular, we are very happy that our control arm performed so well. It is quite rare in MDR-TB trials to see a control arm that has more than 80% of success rates. And this is important in a trial because it sets a high bar for achieving non-inferiority. And then if we look at the experimental arms, we have arms 1 and 2, which are the best performing, around 90%. And then arm 3 or 5, which are comparable around 85%. And finally, arm 4, which is the only one which is just below 80% success rates. So this is just to have a first overview, but of course the primary efficacy endpoint is the comparison of each experimental arm to the control arm in the two co-primary analysis populations. So MITT and per protocol. The way it was done is that we will compare each of these arms first in MITT, and if non-inferiority was achieved, we would then test in the per protocol. And also if non-inferiority was achieved, we would also test to see if superiority of the experimental arm was achieved compared to the control. So this second slide summarizes the primary efficacy comparisons that I just listed. So first of all, let's look at the best performing arm, arm 2, which includes bedaquiline, clofazimine, linezolid, levofloxacin, and parazinamide, which is very similar to the mSTR arm, the only difference being parazinamide instead of cycloserine. So let's say that the most used of the mSTR arm, but it's also arm 2 and 3 are also very similar to the arm with delamanid. So arm 2, as I was mentioning, it was the best performing arm and the only one which is non-inferior to the control in both the co-primary populations, but also in MITT superior to the control. Then we have arm 1, bedaquiline, linezolid, moxifloxacin, and parazinamide, and arm 3, bedaquiline, delamanid, linezolid, levofloxacin, and parazinamide, which, as you can see, are depicted in green. They are non-inferior to the control across all analyses. Then we have arm 5, which is another group, it's light green. This arm, which is the only one which does not contain bedaquiline nor linezolid. It was composed of delamanid, clofazimine, moxifloxacin, and parazinamide. This arm showed non-inferiority to the control in the MITT population, but did not achieve non-inferiority in the per protocol population. And finally, there is arm 4, delamanid, clofazimine, linezolid, levofloxacin, and parazinamide. This arm was not non-inferior in MITT nor in per protocol to the control. So now let's have a look a little bit more into detail at these outcome rates that were the overall aggregate favorable and unfavorable. And I think what we are interested to look here, first, if you look at the favorable outcomes in blue, light blue and dark blue, almost all of them were based on culture. We expected that if cultures were missing, we would look also at the evolution in terms of radiologic and clinical characteristics, but it was not needed in most cases as we had enough culture, so very objective and strong way of defining an outcome. And then if you look, and this is even more interesting, if you look at the different rates of unfavorable outcomes, if in particular I will draw your attention to this orange here, light orange in the middle, which is the rate of treatment failure. So of course, which is an unfavorable outcome of interest. So and it's also the percentage that you can see here in black. So clearly in arm 4 we had higher rate of treatment failure of just about 10%, which was much higher than the other arms. And here you have a Kaplan-Meier curve showing time to unfavorable outcome across the 6 arms. And it's interesting to see that, for example, arm 1 and 2, the best performing arms, are since the beginning the best performing arm and have very few difference between the end of treatment and during post-treatment follow-up. There was only overall, let me mention, there were only 3 recurrences in the whole cohort across all arms, so the recurrences were really rare. And if you look, for example, at the control arm in red, it's interesting to see that the performance of this arm is really similar, for example, to arm 5 and 3 until the end of treatment at 9 months. And then you see during follow-up, the experimental arms have very little difference in terms of unfavorable outcomes, while in the control, there are quite a lot of loss to follow-ups. And that's what drives the additional unfavorable outcome rates in the control. And then finally, you have arm 4 in black, which is the worst performing arm. Okay, so in a nutshell, if you want to summarize the efficacy results of the trial. So this trial provides very strong evidence, we think, for 3 regimens that are non-inferior to a very good control arm. And these are arms 1, 2, and 3. So we think that these regimens could offer patient-centered treatment options for all age groups. So not, of course, adults and adolescents, which are included in the trial, but potentially also for children, since all drugs in the regimens have pediatric formulations and are endorsed for use in kids of all ages, and also potentially for pregnant people, because these regimens include drugs which are considered to be relatively safe in pregnancies. We achieved very good results in a population with severe disease and comorbidities, as shown. In addition, arm 5 could, even though it has a lower level of evidence because of being non-inferior only on one of the analysis populations, could offer possible short-term oral alternatives for patients who are unable to take linezolid or bedaquiline for any reason, for intolerance or for resistance reasons. And finally, once again, we would like to underline how important it is to have a control arm, first of all, and secondly, to have a control arm that performs well. Now coming to the safety results of the trial. So we use standard definitions for grading according to our own MSF severity scale, which was, however, very similar to other widely used severity scales, and also for how we define serious adverse events, or SAEs. But we also had something a little bit more particular, which I will have to define because it's specific for our trials. The definition of adverse events of special interest, or AESIs. So these were basically grade 3 or higher adverse events, which were particularly interesting because known to be associated with some of the drugs that we are using, particularly the new and repurposed drugs. For example, myelosuppression, optic neuritis, and peripheral neuropathy, which are known to be associated with linezolid, prolonged QT interval, which is associated with a lot of drugs, and hepatotoxicity, which is, of course, as we all know, in particular associated with the use of pyrazinamide. So first of all, coming to the safety results, overall there were 15 deaths in the study, so a bit less than 2%, which is quite good considering that this is a cohort of MDR-TB patients, and this is, of course, a deadly disease. And the number of deaths were balanced across arms, and no death was considered to be related to the study drugs overall. If you look at grade 3 or higher adverse events here on the left part of the slides with the 5 experimental arms and the control, so the rates were quite high overall, between 50 and a little bit above 60% of participants who experienced at least one grade 3 or higher adverse event, and comparable across the arms. For serious adverse events, rates were between 10 and 20% for all arms, and once again, the rates were comparable across arms. And here I have a more complicated slide, which summarizes all the AESIs, so adverse events of special interest. So overall, 1/4 of study participants approximately experienced at least one AESI. The AESIs linked to linezolid, the 3 in yellow here, where occurred, first of all, the most frequent was myelotoxicity, which occurred in almost 9% of participants, followed by peripheral neuropathy in 4% and optic neuritis in 0.5%. Overall, the rate of these adverse events were quite balanced across the arms, with no clear signal that one arm has more of those. The QT prolongation was really rare overall in our cohort, even though it was a big concern at the beginning of the trial. It occurred only in 2 experimental arms, arm 2 and 5, which interestingly are the arms that contain clofazimine together with another strong QT prolonger, bedaquiline in arm 2 and moxifloxacin in arm 5. And then finally, hepatotoxicity was the most frequent AESIs, occurred in almost 12% of study participants. And clearly, even though there are big differences between arms, clearly this adverse event was more frequent in the experimental arm than in the control, as you can see. So in terms of overall safety results, mortality was low overall. Permanent drug stops, I didn't show this slide, due to adverse events were overall quite frequent, but much more frequent in the control arm than the experimental regimens. There were comparable frequency of important adverse events in the experimental and control arms. So overall higher than expected, but we also had a very comprehensive pharmacovigilance unit and system in the trial. So the sites reported a lot of adverse events, and many of them were, of course, unrelated, considered to be unrelated to study drugs. In terms of the AESIs, linezolid-related toxicity was common, even though probably less common than in other trials, maybe because our linezolid dose was reduced after week 16. QT prolongation was not a major issue. Why? Hepatic toxicity was an issue in the experimental arms more than in the control. But fortunately, we did not have fatal liver-related toxicity. So overall, this confirms the importance of having an appropriate risk-based adverse event monitoring schedule and also promptly manage adverse events, which was done quite well in the trial. So just concluding slides, of course, it is very good to have new treatment options, but then we must be able to use them where patients are, and this is related to the cost, of course. And this is slides is summarizing data from the MSF Access campaign. It shows how the lamanid price, for example, is still very high. We hope it will go down as you can see here. But right now, the cost is really, really high and not affordable for many countries. While bedaquiline cost has gone down quite a lot, even though it's still not at the target set by the advocacy associations. And as you can see here on the right side, you have the current regimen cost for the whole regimen in US dollars. And you can see that arms 1 and 2 actually are quite inexpensive, so below the $500, which is the goal for a full regimen, and a little bit less expensive than BPAL-M. However, arm 3 and 5, which include the lamanid, are much more expensive, as you can see. And of course, if you are interested in the trial, we do, and also in our endTB trial, the results of the observational study, we have our website. You will find there slides, videos, the leaflet, also the full presentation that was done for the first time at the UNOR conference. The video is freely accessible there. And we have the preprint manuscript, which is freely available at the link, which is present on the endTB.org website. And of course, let me please conclude by thanking all the trial participants, the other patients that we screened. Huge thanks to all these people who has contributed across 7 years in all the countries. Our sponsor, MSF, funder, UNITED, and all the other research partners. So many committees that helped us throughout to write the protocol and go through all the challenges of the trial. And of course, our gratitude goes back in the end to all these wonderful people who made it possible. Thank you very much.
Thank you very
much, Lorenzo, for an excellent presentation and excellent study results that offer lots of opportunities to our patients and allow them to be treated with the use of shorter treatment regimens, which are short and effective. Thank you very much. Dear colleagues, I would like to remind you once again that you can ask your questions. I already see them now, and after the third presentation, we will review them. During the time when we implemented clinical trials and studies, we were able to generate a lot of evidence. And in this slide, it would be very interesting to listen to the presentation of Andrei Dadu, who will tell us about the WHO strategy in the field of TB research. Andrei, please, the floor is yours. Подтвердите.
Yeah, so
Colleagues, once again, thank you for the opportunity to remind you on the overall initiative or the number of initiatives that we've launched back in 2017, which grew up into several streams, including those that has been presented to you by Alex and Askar, which make a difference indeed for the patients as well as for the decision makers in our region, which I'm very happy to also notice the fact that this would have a big difference in impact across the globe as well, learning from those results and applying those results outside of the region. So I will try to spare your time and take you quickly through several chapters of this presentation. It requires a more time, however, due to the limitation, I will take you through the main statements that would help you to find your role and contribution to the overall aim of eliminating the research gaps. So we'll talk about the overall policies. The global level will describe you what the regional level agenda is. We will take you through an example of a capacity establishment mechanism here at the SORT-TB, and then the other one is RD for DTB, and then of course those flagships. I will just leave them on and offering also you an invitation to join the workspace of the ERI-TB virtual network. So back in 18, the World Health Assembly endorsed a global strategy for tuberculosis research, defining the overall policies on the cooperation and coordination. The strategy itself has 4 major goals, is to set up and define an environment on TB innovations. Second one is indeed increase the financial investments and in TB research and innovations, followed by ensuring equity access to those benefits of the research, basically to the data, those data that are collected through the research to be available at a wider scale to be applied in the decision making. And the last one, of course, is the promotion and improving of those approaches to the data sharing. The way how you could find the research that could you take on board and then explore is through our Knowledge Hub. We do have on the Global TB Program website an Knowledge Hub. You see it here on the screen, which is also translated, by the way, into the Russian language. You see it on the right side, platforma of the WHO for the knowledge exchange, and it's a repository and the compilation of the latest evidences and the guidances on management of TB as well as other affected communities across the patient pathways. And this is, of course, the screening, the prevention, screening, diagnosis, treatment, and care, and the equity of delivering those services to match and ensure the universal health coverage. If you go on the tool itself, on the platform, you could search for a certain technical area. In this case, you have research and children. See which are the chapters that reflects those core statements, and then basically on the right side you see the research priority that are outlined here, and then even specific research priority questions that are still remains being a gap and therefore needs to be researched and explored. All this has been compiled into a publication on bridging the gap that has been released back in 2022, where you could identify what are the key evidences that are needed to strengthen the global policy on tuberculosis. So this article is basically a call for you, the researchers in the field, to help us to eliminate those research gaps in order to strengthen our WHO recommendations for all. Moving on to the regional level, as I mentioned earlier, we've managed to establish back in 2017 a network called ERI, European Research Initiative, which one of the objectives was to define the agenda. What are the plans and which directions, which areas needs to be researched in the region in order to eliminate those gaps. So the overall objective of the ERI, the network itself, is bucketed in 3 chapters. It's a policy definition advocacy. Yes, this one in next slide. Yes, thank you. Building mentorship and capacity, and of course, the network and implementation. And we will stay a bit more on the second and the third one, but to describe you more on the overall composition of the research network, you see it here on the map. Currently, we have over 300 members, which is the network itself. Those members are across multiple institutions. Some of those are the service providers, research institutions. We are benefiting from a presence of the TB-affected communities and NGOs, international agents, and of course, the main core of the network is reflected into a membership of our national TB programs. They are stretched across the whole region. The network itself has a secretariat at the WHO, hosted at the WHO. We do have an advisory board where the civil society is also part of. And then we have 2 additional gears into this engine, which is research mentors, as well as those alumni that has been trained through our capacity building initiatives. The research agenda itself is structured into 3 themes: epidemiological research, innovation, and fundamental one, as well as the operational research. And as you can see, for the region, the operational research are a highest priority, and they are prevalent in the overall list of the research priorities for the region itself. And of course, those are bucketed into sub-areas, which are covering technical areas, service delivery areas across the patient pathways. Here is an example for team 1, and you basically can go through the research agenda and then pick a question and then use it for setting up a concept note, drafting the protocol, elaborating the budget and submitting to the donor, approach if necessary to us or to another research funding agency to define the mentorship, and then of course follow and then implement it. So these are the examples. In total, there are 76 research questions there. You see here the epidemiological ones, just a few of them. Then we also have some examples on the team 2 that are on the basic new diagnostics and drugs. And then the last one on examples on the operational research. In order to assist and build the capacity at the sub-national, sub-regional level, country level, and with our counterparts, including the civil society, we've launched a stream of capacity building called SORT, which is a structurized operational research training on tuberculosis. These slides is basically describes the composition and the structure on on the overall delivery of the capacity building support, providing a mentorship from an expert as well as the country oriented mentor as well, having the mentorship from the country supervision as well as the WHO, taking the young researchers through 3 courses along 1 year or less, which helps them to build the protocol, design and collect data, analyze them, describe and submit to the peer review magazines. And then last module is basically on the dissemination and of the research findings. And that is also a stage when the research findings has been discussed into the application into the practice. We've been using all conventionally our World Health workshops for this. We do have the overall description of all those stages in the curriculum, which later on could be taken through a mentorship, and then the final deliverable and the product are reflected in a peer review magazines. In this case was the WHO Panorama. Moving into another tool that would allow an self-study, by the way, of a young researcher to follow the path that I've described earlier is the tool that is called IR for DTB, that stands from the Digital Technology and Tuberculosis Implementation Research in the digital TB, which the overall aim of, it's a digital tool that has been designed by TDR, our department on the research, as well as the Global TB program, by the way, translated into the Russian language for the NTP and other researchers to develop and conduct implementation research projects. It provides a guidance to the countries on how to develop an AR study, use the digital innovations within the TB program. This is basically focused on the digital technologies. And of course, it supports the strengthening evidence base regarding the optimal implementation of the digital innovation for tuberculosis. It's as I mentioned, it's designed in the concept of the self-study, but we do also provide the mentorship for the young researcher that takes those study into the implementation as well, helping with a micro granting to support the work and implementation itself. Within the RD for DTB, we had 2 substreams, one related to the CAD, computerized aid diagnosis, and the second one was on the video supportive therapy and the smart boxes, which is the digital adherent technologies as well. Right, so that was the overall policies description, then the capacity building frameworks, and then we'll move on to the research flagship streams, which you've been informed on the most prominent one, like the mSTR, and across the existence of these webinars through the Virtual Medical Consilium, you've been also exposed to hear more about the second stream, which is the hepatitis C virus co-infection with the drug-resistant tuberculosis, which the implementation is ongoing. We're also cooking a new stream, which is about the PASS, which is the preventive treatment to end tuberculosis, preventive treatment and systematic screening, that has 2 substreams. One is similar to the mSTR, a regional initiative to enroll drug resistance contacts into a preventive treatment under the operational such conditions. The protocol is ready. It has been submitted to the ethical review committee, and we are expecting later this year to make a call to the countries to express their interest in joining the initiative itself. We will then identify the mentors, adapt the protocol to the country context, and support fundraising and the implementation itself. A second stream is a qualitative part of the same one that is exploring the barriers on why those policies that are outlined in the WHO guidelines are slower implemented at the country level, but also describing what are the good practices of those policies implementation. The Georgia has been already engaged in, and now we are working with Moldova to do the focus interviews itself. The IRD for DTB has been described to you earlier. We are now finalizing the analysis of the VCT and CAD studies, and also looking to get them on the public domain by mid of this year as well. Another stream is the operational research. You may recall that the DRS is a tool, drug resistance survey, is a tool that allows to identify the prevalence of drug resistance, including to the second-line drugs and the new one as well, which in this case we are supporting Uzbekistan with the implementation of the third in line in a serious drug resistance survey. We are also helping and assisting countries to outline the epidemiological scenarios on where the TB epidemic would go. In this case, we are supporting Ukraine to see the impact of the war itself and other challenges that will allow Ukraine to adjust and calibrate the targets and the milestones for the national strategic plan. And similarly, we would like to revise the epi modeling for the region after the onset of the war itself. And the last slide that I would like to have it on the screen for your kind consideration is the invitation to join the network and become a part of the big ERI, which will outline the new era to end TB in the region by 2030. Thank you very much. Over.
Спасибо большое, Андрей, за прекрасную презентацию. Я была
Thank you very
очень...
much, Andrew, for such a brilliant presentation. I was very glad to hear that this initiative goes on, and I was very glad to learn about new initiatives that our country can join, and I'm sure will join. I see that we don't have any unanswered questions, and we have approached the end of our webinar. Dear speakers, thank you very much for very interesting presentations, but first and foremost, I would like to thank you for those huge, thorough work that allowed to achieve the results. I would like to thank all of you, and I would like to pass the mic to Dr. Yedilbayev, the advisor on TB and drug-resistant TB of WHO Europe.
Thank you very much, Elmira. Thank you very much, dear speaker, for a unique opportunity to present the most recent data, which is very relevant, very important, and very useful for your work. We were very glad to get acquainted with the new data that was collected in the past years, and I'm sure that they will be taken into account during the process of the development of the WHO guidelines. In June this year, we expect a meeting of the WHO guideline development group, and hopefully the most recent developments, including the developments of the endTB clinical trial, will be presented for the review of this group. Our data on modified shorter treatment regimens will also be presented for the analysis by the experts of this guideline development group. And we can say that the work that was performed in the past was not in vain, and which is important, it was very beneficial for the patients, irrespective of their location and age. So once again, thank you very much for your contribution into the overall activities on the action plan implementation and activities mentioned by Andrei. Thank you very much, everybody, and greetings to everyone on the eve of the forthcoming World TB Day.
Thank you. Goodbye.
Bye-bye.
Спасибо всем. До свидания.